Hey A&Pers, this is Dr. Jones checking in. This is a video lecture for A&P 2, lecture test 3, video, checks notes. I think we're on 8. It says 7, but we've already done 7, so let's write down video 8. Video 8, note set. And we're starting the top of page 14, which is the box of terms for Spotlight figure 20-9. And first is coronary artery disease, all caps CAD, and that is a partial or complete blockage of the coronary circulation. So here's a partial blockage of coronary circulation. Coronary ischemia is a decreased blood supply to the heart. Ischemia is always a decreased blood supply. And coronary means heart, so coronary ischemia, decreased blood supply to the heart. Atherosclerotic plaque is a fatty deposit in the wall of the vessel, and it's not inside the vessel, it's in the wall of the vessel, but it makes the diameter of the vessel smaller. So it's not in the bloodstream, it's on the other side of the endothelium. A thrombus, a clot, can be a solid or it can be air. So here's the deal. This is filled with blood, right? And the red blood cells are moved along with the movement of the liquid, the plasma portion of the blood. If there were an air bubble in this blood vessel, can your red blood cells fly through the air? No, red blood cells cannot fly through the air. They will build up on this side of the embolus. And an air bubble can cause damage downstream because now the red blood cells, white blood cells, all of it, are all building up and upstream, and you're not getting oxygen downstream of this air bubble. Okay, so a thrombus can be a solid clot or an air bubble. So that's why we never inject air bubbles into people's veins. We're very careful, right? Same as you never inject pure water into people's veins because you always use an isotonic solution, not a hypotonic solution. Otherwise their blood cells would explode, which we talked about last semester. Angina pectoris is a pain spasm of the chest. And angiography, okay, I'm going to hold this and put my thumb on it. So I could, looking up and back, I keep losing my place. Angiography is an imaging of the blood vessels or heart chambers, and they show some really cool ones here. Quick note on the different types of imaging. An X-ray uses X-rays, and X-rays read density, and the density shows up as a brighter white, and that's called a radiodensity. In the darker areas where there's less density, like soft tissue or air, that's a radiolucency. And a CAT scan is a CT scan. It's a computerized tomography. A tomography is a moving X-ray where you get a blurry image of like a slice of the inside of the body. And a computerized tomography, a CAT scan, is where the computer analyzes it and sharpens it up, and you get a really neat, sharp and bright tomography, picture of a thin slice of the inside of the body. So a CAT scan is X-rays, but computerized X-rays, and so it's a clearer picture, but it still reads densities, radio opaque areas versus radiolucencies. Fluoroscopy is a live X-ray, and you'll see this often with like a barium swallow, where they're looking to see if the patient can still swallow food into their esophagus, or if all the food is going into, if every time they swallow, they're getting some leakage into the trachea, and that can cause problems with the lungs, because then you start getting food and water in the lungs, and that's never good. So that's a fluoroscope, and they'll usually use contrast with that, where you like literally drink barium. So it shows, it's very radio opaque, so bright white. Now, those are all x-rays, x-ray, fluoroscopy, and a CAT scan. An ultrasound uses sound waves, and it's like a radar for airplanes, where the sound comes out and then bounces off and comes back, and the machine reads the pattern of which sound came back first, and that's how you know that you saw things. You're seeing with sound waves. So that's fun. And then MRIs are completely different. So, and with an MRI, it's actually like changing the molecular spin, like lining up the spins, and then measuring the time it takes for it to go back to its original spin. Anyway, with an MRI, it's a giant magnet. Like, don't wear metal anything into the room. It'll like metal barrettes will like flip up towards the machine, and no credit cards or anything in the room ever, because they'll get wiped. And very loud, and some of them, the old ones are claustrophobic. They've got newer, bigger, better ones now. And it reads soft tissue, so you can actually see water. You have T1 weighted, T2 weighted, but anyway, it like literally changes the spin and measures the time it takes to go back. So lots of fun. Less fun to actually sit there, but okay. We're ready for the next page. So a myocardial infarction is a heart attack. And this is when the cardiocytes die due to lack of oxygen. And coronary thrombosis is a clot at the plaque. We saw the picture of the atherosclerotic plaque. And this causes a narrowing of the arteries, and this is a location where blood clots, any passing blood clot, is likely to get caught and cause damage downstream, which is a myocardial infarction. Coronary thrombosis is a clot at a plaque, which is the most common cause of MI, myocardial infarction. So MI is a heart attack. So the risk factors for CAD and MI are all these terms across the bottom of these two pictures. Smoking, high blood pressure, high cholesterol, diabetes, high LDL levels, male over the age of 70, stress, obesity, sedentary, genetics. And if you have more than 2 of these, that doubles the risk. And some of these risk factors you can change. You can affect the obesity, sedentary lifestyle, the cholesterol, smoking. These are things you can influence, and some of these are things you cannot influence, like genetics, being male and over the age of 70. There's literally nothing you can do about that. Yeah. So the difference between a CAD and an MI, a coronary artery disease, is heart disease, and this is a chronic event, so it's ongoing. Chronic is something that increases slowly over time. We talked about this with chronic glaucoma versus acute glaucoma, which happens all at once. Here the acute is the MI, and that is the heart attack. It is an event. CAD is an ongoing process, whereas an MI is an event. So it's the difference between acute and chronic. Some of the treatment options: decrease risk factors, the ones that can be decreased, and then meds, and then surgery. Research, what are the signs and symptoms of heart attack differ in women and men? In men, they're what we see on TV all the time. Women, they're different. So you get the shortness of breath, fatigue, flu-like things, weak, dizziness, fainting, cold sweat, nausea, lightheaded, vomiting. It's worth looking up the symptoms and treatments for heart attacks in women, and when do you call 911. Women have a worse prognosis for heart attacks than men do, partly because we take longer to realize that something is wrong, and then take longer to decide to call 911. And then once we get to the emergency room, it takes longer to get a diagnosis because everyone is less familiar with heart attacks in women. So as healthcare workers, it behooves you to make yourself familiar with the symptoms of heart attacks in women. Okay. Section 22, the conducting system. All right, so a heartbeat is a cardiac cycle, and it's the atria contract and then the ventricles contract. Autorhythmic cells, auto means self, rhythm is rhythm, and it's that the pacemaker and conducting cells make the heartbeat, so they make their own rhythm. Contractile cells are the majority of the cells of the heart. Those are the cardiocytes that contract. That's what makes the heart beat. But the autorhythmic cells are what start the heartbeat, and then the contractile cells contract to actually pump the blood. Autorhythmicity is the fact that the heart beats on its own. There is no neural input or hormone needed for the heart to beat. In fact, the heart continues to beat a little bit after it's been removed from the body, as we all know from Indiana Jones. Because you can always trust fiction to give you accurate information about healthcare. Okay, that was sarcastic. And the conducting system are all the cells that start and distribute the stimulus to contract. Okay, next, page 15, and I completely forgot the, okay, let's see how far we get before I feel like we're done. The pacemaker cells are the nodal cells. Here's a picture of conducting system of the heart. And the nodal cells set the heart rate. And here's a node, and here's a node. These are the nodes. The first node, first bullet, is the SA node, sinoatrial node for lab test purposes. And it is the cardiac pacemaker. It sets the heart rate. The second bullet there is the AV node, that's atrioventricular node for lab test purposes. And it is a backup pacemaker. And distribution. So they distribute the stimulus to contract throughout the heart. The first bit here are these lines between the SA and AV nodes. This one is the one that is not on the lab list. These are the internodal pathways between the nodes. It's the pathway between the nodes, internodal pathways. It's right there in the name. And then the next bit includes the AV bundle, the bundle branches, and the Purkinje fibers. So this is the AV bundle, used to be known as the bundle of His, the left and right bundle branches. Then once the flames go up the wall, it is Purkinje fibers, and this one by itself is the moderator band. So that's the conducting system in a nutshell. Next slide, if I can find the arrow. Okay. The pacemaker potential. How does the heart beat itself? The conducting cells of the SA and AV nodes constantly depolarize. What is this called and how does it happen? It is called the pacemaker potential. And how it happens is there is a gradual depolarization to threshold. How does that work? Sodium leaks in, but the potassium does not leak out. And when sodium leaks in, that makes the inside of the cell less negative until, boom, it hits threshold and heartbeat. Let's see. The membrane potential constantly drifts towards threshold. That sounds like test question-ish wording, doesn't it? Okay, the heart rate. Spontaneous depolarization is fastest at the SA node. The SA node is 60 to 100 beats per minute. You need to know these numbers on this. Yeah, you need to know these numbers. Followed by the AV node, which generates 40 to 60 beats per minute, action potentials per minute. This is why the SA node is the pacemaker. But how is the normal resting heart rate slower than our 100 beats a minute? And it's because we have constant parasympathetic stimulation of the heart. Parasympathetic rest and digest decreases the heart rate and the force of contraction. Constant parasympathetic stimulation. The maximum normal heart rate is 230 BPM, 230 BPM, beats per minute, BPM. Because that's the fastest the AV node can conduct the impulses. A year or two ago, my dad went to a new doctor who freaked out when he realized my dad's resting heart rate is about 50 beats per minute. But my dad's resting heart rate has always been 50 beats per minute. And he's a very calm, cool, collected, and very kind of slow and intentional kind of a person. And so my guess is that his SA node has maybe not ever worked, and he's always used his AV node and just adapted. So within normal limits. It's a normal, abnormal. And 230 BPM. Okay, give you. And the next bit continues through to the next page. So we're going to assume that this has been time because I want that whole next bit to be in one video together so that we're not stopping in the middle of a concept. So this has been a video lecture for A&P 2, lecture test 3, video 8. And we covered page 14 and most of 15, but not all. So next one will be video 9. Noteset page 15, and we'll start on 15. Okay, so thank you as always for joining in. This has, no, I already said that part. Yeah. So thanks for joining in. I appreciate y'all spending the time to get yourselves educated, especially in an online-only class where you have to juggle this and the laundry and household responsibilities and work and everything else all at the same time. And I know this is hard, and y'all are still here and still watching these videos, and I am so impressed with you. So thanks. The education must go on. Dr. J out. Control, Command,